with Melissa and Elliot. And I'm going to introduce Melissa first. Melissa is the founder of the Penis Project podcast for prostate disease, and she's a specialist in penile rehabilitation post-prostate disease. And here is Elliot Justin. He's the founder and CEO of FirmTech. He was previously an emergency medicine specialist, and he's a medical expert in medical technology. And what we're going to be discussing today are three things. We're going to be discussing post-prostate surgery rehabilitation and the use of the FirmTech tech ring to help with recovery from prostate disease. And we're also going to be talking about erectile dysfunction and how the FirmTech rings can help with management. So the first thing I'm going to say is that, over 2 years, between 30% and 60% of men return to pre-treatment function, according to a recent Johns Hopkins review. This is a long time to wait. What can be done before and after surgery to improve the chances of recovery? Melissa, I know you disagree with the Johns Hopkins study, and I'd like for you to give us your perspective on this.
Sure. So basically, I think it's important to know that research always takes about 5 years to get from collecting the data to actually putting it out there. So the research statistics in the Johns Hopkins study are basically 5 years old, even though the publication date is very recent. So I think that's really important. And, I've been looking after men now for 9 years that have been in prostate cancer rehab, and I've seen a massive change. And I agree that 9 years ago, there was about 40% recovery rate. But nowadays, it's because the surgeons have got better. People are so much more aware of how they can improve their outcomes before surgery and with rehabilitation. Like the stats that I'm seeing are more like 60 to 70% of people are returning to their pre-op function.
It's also an issue here with academic studies versus people's results in the private sector. The academics' excuse for the poor results is that they see the worst patients. And they're seeing the people with the worst comorbidity factors, people who are obese, people who smoke, people who have diabetes, significant diabetes and hypertension. There's results, certainly there.
Yeah, and I think in my experience, there's a few things that predetermine how well someone is going to go, and that is what's their pre-op function like? What is their weight and fitness like? Because you can't underestimate what a difference that has. If someone's got a big fat belly and they're about to have their prostate out, then that's like parking a car on the hose. You just can't get the blood flow through. So, the first thing I do if I see someone preoperatively is let's aim to get your belly circumference down less than 96 centimeters, which I'm not sure what that is in inches. But yeah, get it down, because that makes a big difference to the blood flow. And then there's also the ability of the surgeon. It's like everything. Some people are more experienced than others. So I think a really good question for people to ask their surgeon is, how many of these have you actually done?
Yeah. Well, there are people who claim their results that they're down to 10%, and then there are people who admit that and so if you don't address those factors, things can be worse. What do you recommend that people postpone surgery in order to lose weight? You're talking about people getting the waistline in terms of inches down to about 42 inches, which is actually still pretty plump. So what? Is that something that you and your team are recommending?
Definitely. So most of the surgeons that I work with in Australia will actually postpone surgery until people lose weight. So prostate cancer generally is very slow growing and it's not very aggressive. Occasionally there's exceptions to that rule, but you can tell that from the biopsy. And so if your outcomes, not just for sexual function, but also for continence and for wound healing, are much better when you have less belly fat. So there's, I work with a couple of surgeons that will actually have part of their offering is they have medical weight management, and men will be required to lose 10 to 20 kilos before they'll even operate.
That's 2.2 pounds per kilo for those who are metric challenged. So that's a substantial amount of weight, and that in and of itself, I'm certain is daunting, for many men. What medications do you recommend people stop taking before? I'm really thinking about it, things that interfere with blood flow, certain antihypertensives, steroid depressants. What medications do you recommend men stop taking before surgery and look for substitutes after surgery?
So I don't know if it's so much stop taking them, but I think it's definitely about, I mean, this is where I think the FirmTech comes in, is that, you know, before you have surgery, if you were able to monitor what your nocturnal erections were like and actually know how much blood flow you're getting through, then you can go, okay, I'm not getting as much as I should be. So I'm not proposing that people all stop their antidepressants, but there is options that aren't as bad for these issues. Or you might just want to add something in like curcumin or tadalafil. You know, low dose curcumin and tadalafil are really good for improving blood flow. So if you can actually objectively measure that and then make some changes like exercise more, reduce, painkillers are the worst. Like opioid painkillers are really bad for erectile function. So, and, you know, there's a lot of positive alternatives for that now, such as cannabis oil and TENS machines and moving. And so I think when I see people come in that are on a lot of painkillers, that's definitely something that we would try and sort out. But with blood pressure tablets, then if that's the only option that's working for them, then I think it's about giving them an extra supplement or more exercise or something else to improve that blood flow.
Well, you know, what I've observed, take questions from our customers, our users of the FirmTech ring after surgery, is that too many of them are still on beta blockers and on medications like lisinopril that we know just even in men who don't have ED can have an impact upon their erectile function. And there are antihypertensives that don't have an impact. Are you recommend? Because one of the things I've recommended to a couple people is that they switch to a diuretic, which is old school. But the advantage of diuretics is that they don't interfere with blood flow. They're working on blood pressure through changing what's going on in the kidneys. Just a thought to keep in mind.
Yeah, so if I meet someone who I think is on some sort of heart drug that is interfering, then I'll always write back to their cardiologist and ask them if they can reevaluate and say, you know, this man has got these issues and this is really important to him. Can we look at this a little bit more holistically and see what options there are that might not affect it? The other drug that is commonly guys are taking preoperatively is drugs like to reduce the size of their prostate if they've also got an enlarged prostate as well as prostate cancer. Those drugs are erection killers. So the good news there is once, you know, they've got their prostate out, they don't actually need them anymore. So that's always a bonus that we get rid of that drug.
Yeah. What we have noticed on the FirmTech side in older people who are taking those, you know, that class of medications that usually men in the 70s or 80s, when they stop taking it, the erectile function recurs. They start getting nocturnal erections. They start being able to enjoy penetrative sex again. So one thing that you and I have had several discussions about is assessing baseline function beforehand. Obviously, the stamp test is really old school, but you know, this to my mind really involves more than just asking someone whether they have, you know, morning wood. And the Ridge scan is hardly being used in the United States at all. What's being done in Australia, and then what are you doing in your practice?
Well, absolutely. Nobody that I know uses the Ridge scan. And until I started using the FirmTech, I was just asking men, you know, do you notice when you get up in the morning, have you got a bit of a chubber? You know, have you got wood? Like in the middle of the night, does your partner notice when you cuddle in that it gets a bit firmer than before? Because a healthy man should be having 3 to 5 nocturnal erections a night. And often, you know, when you're young, it's really hard and everyone knows about it. But when you get older, it's a bit less impressive. So you don't get poked in the back with it anymore. So I think, you know, it's more about when you get up in the morning to have a wee, have you got a bit of a chubber there? But, you know, often guys will go, look, I haven't had nocturnal erection that I know of for years. But then you get them to use a FirmTech ring and map it on their phone and they're like, actually, I am having them. So, you know, for me, that's just been so useful because you alluded to the stamp test before, and anyone listening who doesn't know what that is, in the old days, we used to get perforated stamps and stick them around the shaft of the penis. And if you wake up in the morning and the perforations are pop. You must have had a nocturnal erection, but it's pretty crude because if you just move in the wrong way, you might pop the. So I think this is just so much better. And also, I think it's really important to set a pre-operative goal. And if that pre-op goal is I get a good erection with a PDE5 and I was having 3 nocturnal erections, that's where we want to try and get someone back to. But how do you know that if you're not measuring it?
Well, what part of the exciting news on the FirmTech side, which I want to share with our listeners, is that Dr. John Mulhall at Memorial Sloan Kettering in New York, one of the world's leading experts in prostate cancer and in surgical techniques to reduce side effects, complications of the surgery. He has joined our scientific advisory board. He's going to be doing a formal study of the use of our device before and after surgery, because we really don't really know when nocturnal erections resume in men after surgery. Anyway, he thinks that he's confident that the use of the FirmTech tech ring will become the standard of care for the management patients prostate surgery after the paper is done. In the United States, is another issue, which is legal, because the #1 cause for malpractice for a urologist is some becoming impotent after prostate surgery. So the device will also address that issue. So if men are potent beforehand and don't recover function, at least in the United States, if they've documented that, which they right now can really only do with a FirmTech ring, that could be grounds for legal action.
I also think it's really important that the patient has realistic goals, because if your prostate cancer is spread and it's gone outside of the prostate, or it's into really close to those nerves that are giving you the erection, then sometimes it's just unavoidable that in order to have successful surgery from a cancer perspective, you have to take some of those nerves. But you don't need all of your nerves saved to get your erectile function back. So, I think that's important, #1. But #2, if you can look at your histopathology and see, oh, I had X number of nerves taken, which means I've got this amount left, then it's more about setting a realistic outcome. And I think if you set realistic outcomes, you're much less likely to be depressed. And there's always a workaround. So, the things that I like to tell men and their partners when I see them pre-op is, worst case scenario, you have non-nerve sparing surgery. You're not going to get spontaneous erection again. But that doesn't mean we can't ever get you to have penetrative sex again if you want to, because there's a lot of other ways to get an erection other than the natural way. So I just think that's the big thing for me, is setting realistic goals and knowing what your function is, because often people overestimate their function. So you don't really know what's going on unless you measure it. And this is the first time that I've been able to measure people's actual function at home before surgery. So we actually do have realistic goals.
So, Melissa, I have a question. The next question here is, what are the current recommendations for penile rehabilitation after surgery? How soon after surgery should the therapy start?
Yeah, so this is pretty controversial. There's a lot of different, if you Google this, there's heaps of different people who have different regimes. So I have gone through and looked at all the research that's come out in the past and as it comes out. And I think it's about having common sense. So if a natural, healthy man is having 3 to 5 erections a night and they're lasting a minute or so, and that's enough exercise to keep the smooth muscle of the penis active, then we want to do that again. So probably the best example I give is if you're a gym junkie and you're always working out with your bicep, and then you're going off to the gym and then you stop going for 6 months, of course that bicep is going to shrink. And your penis is just smooth muscle, and you don't want that to shrink, and you want to keep it healthy and active. So I think we just need to replicate nature. So my advice is that everyone should take a PDE5 medication such as low-dose tadalafil or low-dose sildenafil every day, starting the day the catheter comes out. Now, the most recent paper on this actually says day 3 post-op. However, some of the surgeons I work with have such good nerve sparing now that guys are getting erections in that period when they've got a catheter in. Now, I don't have a penis, but imagining what it feels like to get an erection with a catheter in, I imagine that's not great. So, I think I just advise people to hold off on that until they get the catheter out. And then we start using a penis pump, such as this one or this one. Or there's another one called a bathmate, at about 4 weeks post-op. Now, you can actually start that anywhere between 4 and 8 weeks, but ideally 4 weeks. And the reason I like to wait that long is they have to attach the urethra back to the bladder, which is in medical speak called an anastomosis. And I just think it's nice to give that a few extra weeks healing so you really know it's on there. And then the regime that I recommend with a penis pump is that you pump it up to about halfway, hold it for a minute, release, and repeat that 3 times. Now, you will read other regimes that say hold it up for 10 minutes and all that. But let's face it, most people are busy. We need compliance. This is about doing it for a long time, not, you know, going hard for, pardon the pun, going, you know, and using it for 10 minutes every day for the next 2 weeks and then forgetting about it. I want my patients to be able to incorporate this as part of their life. And if you just pump it up, let it down, pump it up, let it down, you're doing what nature is doing, and it's taking you 5 minutes a day. So it's realistic that someone can do that long term.
Mm-hmm.
Okay. What about the prostaglandin injections and urethral inserts?
Yeah, so I'm a big fan of injections for a couple of reasons. There is one paper, but it's a very small number of people that shows that it helps recovery. So, you know, there was like 20 people in that study, so I don't put much faith in it. But logic is that using an injection gives you a decent erection, which is exercise for your penis, the same as the pump. So I say to my guys, don't worry about using your pump on the days you use an injection. I really like injections for guys that aren't getting erectile function at all, because, you know, while they're waiting for their nerves to wake up, then they are able to get a decent, proper erection that they can have penetrative sex, or they can have solo sex, or, you know what, they can walk around the house and hang a towel on it if they like, because that's part of their masculinity, you know, like having if you had a paralyzed arm, you wouldn't want to just let it hang there. You would want to do something about it. So why would we just let our penis just hang there and not do anything? And I think injections are a scary thing for people, but I always teach using one of these, which is an auto injector. And that just is like an EpiPen. And there genuinely is no pain. I'd start 20 to 30 men a week in my clinic on injectables. And I've never in 9 years had someone run screaming out of the clinic. So I'm pretty sure it doesn't hurt. And it goes into a spot where there is no nerve endings. The urethral things that go into the urethra, which have alprostadil in, we don't use those in Australia just because our therapeutics goods hasn't approved them. But the reason they didn't approve them is there's actually quite a lot of upset with that actually causing inflammation and burning in the urethra, which you don't get with the injection. So I actually have a lot of online consults with people in America and Canada that have tried them that tell me that they got that burning. So for that reason, I
don't need it, but I tried it because I was curious, because I don't want to recommend anything unless I pretty much tested it myself, unless if I can. And it burned. I didn't like it at all.
Yeah. And I think the other misconception as well is with the injectables, most people have used the drug alprostadil, which is in Cavaject. And in 1 in 20 men, Cavaject does cause an aching feeling in the shaft of the penis. And if that's the first injection you've ever tried and you get that, you're going to think the injection hurt. But there's a lot of other options. There's perpavrin, phentolamine. There's one called APV. There's lots of other options that can cause erections with injection that don't have that side effect. So I think it's really important as well that people are willing to try different things. And for that reason, I always try the non-painful ones first and then go to alprostadil last. Now,
shockwave therapy is controversial. I've spoken to experts who advocate for it and others who say that the data is simply not there and it's not worthwhile. What are you currently doing?
So I have a colleague who I used to do the podcast with, and she is a big supporter of shockwave therapy, and she actually has a low intensity shockwave machine, and she's doing a bit of research into that at the moment, and she's getting some good results. In my personal opinion, I think there's a lot of hope for that. It's just that hasn't been around long enough yet that we know what is the right regime to follow. How often do they need to do it? Should they do it at home? Should they go into a clinic and do it? So I think it's a watch this space, and I'm pretty excited about the in-home options to do shockwave therapy. And actually, and I've noticed that this gentleman is in this webinar today. He's an engineer who's very innovative and has invented some amazing things. So I'm about to send him the specs as soon as I get them of the in-home versus the one in clinic to see if they're the same. And if they are, we're going to try that out. I think shockwave therapy, in my opinion, seems to work best when people are about 18 months to 2 years post-op, when they've started to recover, and it seems to speed it up rather than using it early. I haven't seen anybody get quicker results. So I definitely think there's a place for it. I'm just not sure yet, but watch this space.
I think it probably works, but I really don't know. I've spoken to companies that are selling home devices in the United States. The Phoenix by Launch Medical being probably the most preeminent one, and they say it works, and I hope that they will share their data. Gainswave makes similar claims. The problem that I see from a scientific perspective is it takes, even someone who just has ED and is being treated with shockwave therapy, it takes months for it to be effective. So in this case with prostate surgery, would people be recovering anyway? How do we come up with a control group or that matches the subject group? It's going to be difficult, and I think we're going to be stuck with relying upon anecdotes more than a study, because it's uncomfortable. Shockwave therapy is uncomfortable. You have to use lidocaine cream in order to deal with discomfort. So how do you? That's going to be very hard to blind as well.
Well, that's interesting, because I've actually done the shockwave. Jo actually got me into her clinic a few days, and I used it and did it on men. And post-prostatectomy, they actually didn't have pain, which is interesting, whereas I've done shockwave on plantar fasciitis on my foot, and it hurt a lot. But post-prostatectomy, none of them complained of pain. So I think if we can find a cost-friendly alternative, which those in-home ones are, that is convenient, then I personally think that having anecdotal evidence is not a bad thing. I mean, you only have to look at things like St. John's wort that was being, given to people for depression and anxiety for many years before it was actually researched, and the anecdotal evidence showed for hundreds of years that it was really effective. And the research now has supported that and says it's as effective as low-dose SSRIs without the side effects. So I think, if something doesn't cause harm and it potentially does good, then why wouldn't we try it?
Sure. Well, I'm not opposed to it. I don't see how any harm could result, and we do have some men reporting very impressive results. Let's go on to another controversy, which is testosterone therapy after prostate surgery. I mean, I'm old enough as a doctor to remember when no one wants to use testosterone, because my God, we got to put these people on female hormones, because we give them testosterone, the cancer is going to recur, and that thinking has changed really 180 degrees in the last 10 plus years. What are your current recommendations?
So I think a man without testosterone is like a woman without estrogen. It makes them depressed, grumpy old men. They lose muscle. They're tired and lethargic. So, there's in no world do we want men to feel like that, just the same as we don't want women to feel menopausal for the last 20 years of their life. So I'm very pro testosterone as long as it's within a normal range, and not just because you want to build big muscles and be a gym junkie, because in that aspect it makes you infertile and shrinks your testicles and your penis, and it's all bad. So there is a case of too much is not a good thing, but managing it is great. But with prostate cancer, I always advise people to stop for 12 months after, and then we measure the levels again. And then if it's low, then I talk to their urologist and restart it. And the urologist that I work with in general will restart the testosterone. So, and as long as we're leaving it in the safe range, then there shouldn't be any problem. And you just monitor their PSA. And so, it's all about quality of life. If you feel like crap what's the point of living for 20 years? You know, you want to feel good.
Yeah, definitely. What are you doing for couples therapy?
So I think it's really interesting. I think there's not enough put on how important the relationship is. And I think we need to concentrate more on that. And I know that I actually spoke to John Mulhall about this at the conference that we went to in Dubai before Christmas. And he was saying, you know, we really need to concentrate on how we're going to support the couples. And that actually on Friday, I see this often, but just on Friday, and I was thinking about this webinar and talking about this example. And I had this lovely couple in who were in their late 60s, and he was getting his prostate out. And when I asked them about their current sex life, he said, oh, it hasn't actually been working very well for a year. And I was like, have you been and seen your GP about this? Have you tried Viagra or anything? No, I haven't. I'm too embarrassed to ask. And she looked at him and said, I didn't know that. And then he said, yeah, I've been too embarrassed to tell you. And she burst into tears and said, I thought you didn't find me attractive anymore. And this is something I see commonly. So I think it's really important for people to open that conversation, and for, you know, the partner who's having the sexual dysfunction to say to the other one, it's not that I don't love you anymore or that I don't find you attractive. And this works for heterosexual and homosexual relationships. It's things just aren't working that great. And like, we need to get some help with it. The other thing that I often see was like, that was so beautiful. They ended up having a hug and he was like, God, I find you so attractive. It just doesn't work and I'm too embarrassed to do anything about it. And then the other thing that I see as well is often when I say, look, it's going to be 18 months to 2 years probably before you start getting your function back. But we can work around that. We can use a ring, we can use injections, we can use a pump, we can do all kinds of things. Often and I've never heard a gay couple this happen, only with heterosexual couples, but often the female partner will say, it's okay, I don't mind if we never have sex again. I just want you to be alive. And the man's face drops. And I think that woman is trying to be supportive and going, it's not the be all and end all, don't worry about it. But I think what that guy hears is, oh, she's relieved. She never has to put out again. And so I always try and say to her, is that really what you think? Or is it just because you think it can't happen? 99% of the time, the woman will go, well, I just thought it couldn't, and it's not the end of our relationship. I want to reassure him of that. And then, so it's about, I think couples therapy in this is so important. And I think talking to the partner about how they're responding. I actually recently did a podcast, episode 161, and it's a couple in New Zealand, and the female partner spoke on that. And she talked a lot about, and she actually got quite emotional in that podcast, about how this made her feel and her fears for their relationship moving forward. So I think it's really important.
I think it's critical. I mean, the incidence of depression, divorce, and suicide are quite significant after prostate surgery, and I think it's imperative that people talk about these things beforehand. And look, part of the issue here is that doctors, and I'm one of them, we are assholes about sex. We don't ask people about, prostate or not. It should be obvious. I'll put this. I was shocked. Well, I'm not kind of shocked. I can't say. Actually, I wasn't that surprised. But I've had quite a few people who bought the FirmTech ring to help with their recovery after prostate surgery tell me that they were never really warned about what to expect afterwards, in terms of how long it would take for them to recover their potency. That's just neglect. And then after surgery, the doctor doesn't want to talk to them. The doctors need to be proactive about this issue. And sometimes people do have. I think it's sometimes for some people speaking to a nurse practitioner or a physician's assistant in the United States is an issue as well too, and they want the physician to take the lead on these issues. Anyway, what about go ahead.
Sorry, I just noticed a question in the comments about the climacturia and the pee ejaculation through the operation damage. And that's one of the things that you found the FirmTech ring to be helpful with. And I was wondering if you could talk about that, Melissa.
Sure. So basically after the surgery, and even men that have radiation actually will often get climacturia or arousal leakage. So arousal leakage is when they just become aroused and wee comes out. and climacturia is when we comes out with an orgasm. So the trick is I used to always recommend one of these, and it's actually really common. Pretty much 50% of men who have this treatment will end up with climacturia or arousal leakage. Often after a year that will settle, but often it stays. So there is surgery you can have done, but you often don't want to have more surgery. So I used to recommend one of these, which is just a standard lasso. Now, the problem with this is it's made out of very hard plastic, so it's not very comfortable for the partner, but it also blocks off the blood flow going into the penis and out. So you end up with this penis that looks like a lamb's tail that's strangled at the base and hinges. So it's not ideal, and it goes a little bit pale blue and cold to touch. So what I was really excited about when I found out about these is they're soft, so they're comfortable for the partner, but most importantly, they still let the arterial blood flow in. They just restrict the venous blood going out. So, and because the urethra runs along the bottom of the penis and it's very surface, it's just enough pressure to hold that. So it's fantastic as far as I'm concerned, because you still have a nice, pink looking penis with, oxygenated blood going into it, but it's stopping the urethra from letting the urine out. So it's a bit like parking.
Just to inform our audience, what are you holding there?
So this is a FirmTech Pro, and I have tried the FirmTech, the one with the I call it a Fitbit for your dick one, also works for this. But this is a little bit chunkier than the FirmTech Pro. So this one, I think it's good for sex, but it's absolutely brilliant for getting those objective measurements we were talking about. This one, it's very slimline. You just pop it on. This is the FirmTech Pro. Pop your testicles through here, hook it over, and then it's just firm enough to stop the climacturia. You can leave it on for 90 minutes safely, which is also very unusual. Most lassos you can only leave on for 30. And so, yeah, I'm a very big fan. I absolutely love these, and I've been selling them pretty much to everybody that comes into the clinic.
Let me just say that's called, for those of you listening, that's our Max PR ring.
Max PR, sorry. Yeah.
Max.
When we designed that ring, and this is really the first doctor designed cock ring, my goal actually by putting the pressure over the urethra was to put the right amount of pressure to increase the ejaculation, and that therefore make a more intense orgasm. I wasn't thinking about the impact on climacturia, but I've been pleased to hear about its success with quite a few of our customers, and that you're using it as well. Go ahead.
I was just also going to say the other thing I found these to be useful for is a venous leak. And the reason for that is the same, because it's just firm enough to stop that venous blood flow that is on the, closer to the surface of the shaft of the penis going back, but still allow the arterial blood flow to go in. So the example the way I think of that is if you have a bucket with a small hole at the bottom and you had a hose going into it, you might be able to get that bucket to fill up to 70%, but it's always dripping out the bottom. You fill the hole, you can get it 100%. And that's where I've had a lot of success with these, is with gentlemen that have venous leak. And it's actually really common. A lot of men post-prostatectomy, and we don't know why, will develop a venous leak. And often they're fine for months and months, everything's going well. And then all of a sudden they'll say, it's really weird. If I stand up, I've got a great erection. As soon as I lay down or change position, it goes down. So that's your best indicator you've got a venous leak, and using one of these is really helping with that.
The PDE5 medications are not particularly effective with a venous leak. They put more blood into the penis, but they don't keep it there. And I think one of the mistakes in really with a lot of the research in this area is that the urology research groups together men who actually have different problems. There are men who can't attain erection, and there are men who can't sustain erection. And men who can't sustain erection is a much more common problem, both after prostate surgery or just in general with men with ED. We've done internal research showing that our rings are more effective than PDE5 medications, and that both together are most effective at all for sustaining an erection. And one of our goals is to mainstream cock rings into the treatment of erectile dysfunction. Urologists, in my experience, in general, are ignorant about them. Not the gay urologists; they never are. But straight urologists, They're thinking in terms of medications and procedures. They're not thinking in terms of what really is a common solution. And I don't think about it as a bucket. I think about it as plumbing. But it's essentially conventional cock rings, these O-rings, or even last of I think it's a fairly good, probably the only really good one because you can adjust it. But these O-rings are like hard silicone gaskets that are on the penis. They're uncomfortable, and ours is soft and adjustable and adaptable to people.
I think also that something you mentioned there is using PDE5s in combination with one of these, because the PDE5, if you've got that arterial blood flow issues where you're not getting enough blood flow in, well, you can often improve that with a PDE5 medication, but there's no point improving that if you can't keep it there. So I think using, having it like a toolbox of things you can use is really important. And to me, the toolbox that every man needs after prostate cancer treatment is a decent lasso like this that is soft, comfortable to wear and will work, a penis pump, a PDE5, and, the wherewithal to go and exercise and keep themselves healthy. So, yeah.
One of the things that I've found valuable, well, our customers have found valuable, and I find to be really interesting, is the use of the device to inspire people to stick with the therapy. A lot of men quit or after prostate surgery, or they don't really keep up with the regimen. And if they can follow their data, that they then they then know that they're improving, even though they don't see that it's improving. What's been your experience in monitoring erections during sex or attempted sex or at night after surgery?
Yeah, I think the main reason that people will purchase one of these off me, and I'm really hoping that it's going to become the standard, that when someone comes in for prostate cancer rehab, they'll buy a pump and one of these. But people get sick of using a pump every day, even though it's 5 minutes a day. And so I think the big advantage of this is you can get a little bit of positive reinforcement. You can start wearing it at night time, have a look and go, you know what, I wasn't getting any erectile function at night before, but a few months down the track, I'm actually, and I've seen this, guys are excited. They'll bring it in and show me their phone readout and go, look, Melissa, something's happening. And then, being able to get people to stop using the pump earlier, because we know for a positive fact it's happening, instead of having to guess and go, oh, it's not really long enough yet, I'm not sure if you are, so keep using it. And I mean, 6 months extra of using one of these is quite tedious. So if you can stop that earlier, because we know that you're still recovering and things are happening on their own at night time, well, that's just a massive bonus, I think.
Yeah. We've gotten a lot of questions. Are there anything that you want to answer?
Well, I think we could explain that the difference between the Max PR ring and the performance ring is the performance ring is basically the tech ring without any tech. And so it's actually quite a bit looser than the Max PR. You can tighten it with a twist if you want to make it tighter. And it is good for larger men, but the Max PR was developed for a tighter experience, and for men, especially who are more familiar with a tighter cock ring. And so that's the difference between the two. If you're above 95% in girth, you probably should get the performance ring. But the Max PR is, both of those are the non-tech versions of our rings.
And the other thing as well is I have had some men say to me, oh God, I'm not big enough for that, which I think they're surprised, because they often are, because it's not very big. But you can always just put like a little twist in it and then pop it on to make it a bit smaller.
It can also be pulled through the loop
Yes.
and tightened even without that, because it'll stay in place. When I've had a couple men tell me that they're too small. And I point out then I could actually cinch down to the point you could hold a pencil with it, and these men are not that small.
I also noticed another question about whether you needed to use the PDE5s, or whether if you just put the ring on while you were aroused, whether it would stay. And one of the things that has been commented on is that, because of the nature of the ring, people continue to get harder as they wear it.
Right.
It doesn't block the arterial flow from going in.
You can put it on when you're flaccid.
Yeah.
And get harder.
And I think that's really important. And in answer to that, no, not everybody does need PDE5s. And, you know, a lot of people have horrible side effects to them, such as headaches and flushing, and their nose gets blocked. And so, you know, if you're someone who could get a pretty good erection, but it's not perfect without a PDE5, and then you take it and it's really good, you could use one of these and then not need the PDE5 at all. So I think there's definitely that option there. There is a question in here that I think we should answer from Peter Hill.
I just look at that one. Yes.
Yeah.
Yeah. So your surgery was done over 2 years ago, and the surgeon said that you're badly bruised, so when you ejaculate, it doesn't go where it should go. So, Peter, if you had your prostate removed, you'll never ejaculate. You'll have the sensation of an orgasm, but nothing will come out. But you may have had surgery for an enlarged prostate, and that might be what you're referring to. And that means you have something called retrograde ejaculation, where it goes back into bladder. Now, that isn't harmful in any way. It just happens because of the disturbance of where the urethra is and the ejaculate going back in. And you'll know that when you wee in a glass after you've had an orgasm. It'll be a bit murky because there'll be swimmers in there. But it's harmless, and there isn't anything you can do about retrograde ejaculation. But I'm amazed how many men have their prostate removed and nobody has explained to them that they will actually never ejaculate again. And I think that's something that's really sad. I think it's really nice to know that pre-surgery, so that maybe you can have a little bit of a goodbye to it, you know. And probably the thing that I liken that to is, I remember the last time I ever breastfed my youngest child, and I didn't know it was the last time. And, you know, then she decided she was too grown up for that anymore. But I wish I did know, so I could have sort of gone, oh, well, that's not going to happen again, and on to the next chapter, but actually acknowledge it. And so I think that's something men should do. If they know this, they can acknowledge, this is the last time I'm going to do this.
Yeah, well, I'll keep that in mind if ever faced with that circumstance. I hope not. Okay, anything else? Any other questions here that we'd like to answer?
There's a guy here that says, I'm 90 kilos. When does medical weight loss treatment kick in? So medical weight loss treatment is using something like shakes, like it's quite radical, or Ozempic or Saxenda or something like that, to lose weight fast. So, you know, really it depends, Jeffrey, on 90 kilos depends on how tall you are and a whole lot of other things. So ideally you would have a BMI of 25, but that also is not standard for everyone because it depends on your body build. So I just think if you aim for a abdominal circumference around your belly button of less than 96, preferably less than 94 centimeters, which I think Elliot said before was 42 inches. Right? About
that. So I divide by two. But let me. The gentleman here asking me whether the rings can produce an erection, and they don't. So this is a common misconception, for example, about the PDE5 medications is they produce erections. I think took me a couple of years to persuade my daughter and her friends that gee, guys have this wonder pill and girls have nothing. The pills just a man still requires stimulation if he takes the PDE5 medication in order to get erection, and the same thing applies to the ring. It's not like an injection of prostaglandin. It's not going to directly produce an erection, but it's going to make it a lot easier to sustain that erection. And as I noted before, most men's problem is not getting blood in; it's keeping the blood in the penis. So again, our data, and there's going to be independent research confirming this. That's going to start soon. Our data shows that the rings themselves are more effective, than pills, and that's really disruptive, because pharma has really succeeded in pushing the pills and persuading many people that those pills are necessary in order to have erections. I have several men to my prescribed tadalafil, really just for openly acknowledge that it's for the placebo effect. If I have it on my night table, these guys say I'm more confident that I'm going to be able to perform in bed. And the placebo effect is powerful. And in the original studies looking at Viagra back in the 90s, it wasn't that much better than placebo.
Well, Melissa, people are wondering how they can get the FirmTech ring if they're in your neck of the woods. And you're selling them, so how can they get them?
So if they just go to melissahadleybarrett.com, there's a shop tab and they can pop it in there. And if they're from your side of the woods, the other side of the world, then there's a link that takes you straight to Elliot and Anne. So yeah, it's probably from a postage point of view, it'll be cheaper for you, Southern Hemisphere, to go to my website and just go onto the shop and buy it. But if you're in the Northern Hemisphere, it'd be, you click on the link that goes to the Northern Hemisphere and then you'll get it sent straight from them. So
okay,
there was also, sorry.
Peter Hill has asked again, he says, so nothing can be done about my retrograde. Okay.
People should be private, darling.
Okay.
Okay.
Sorry,
Mr. Hill.
So can you have an erect penis without an ejaculation then? You can, correct?
Yes. So I think this is really important. We always associate, and I used to too until I studied sexology, that a man gets an erection and then he gets the sensation of an orgasm and he ejaculates at the same time. But they're actually three very separate things. So the nerves around the outside of the prostate give you an erection. The pudendal nerve makes your pelvic floor contract, which gives you the feeling of an orgasm. And when that contracts, it squeezes your prostate, and your prostate also has muscles in it, and then you ejaculate. But you can have no erection and feel an orgasm and ejaculate if you've got a prostate. If you've got no prostate, you can have no ejaculation but feel an orgasm and have no erection. And you can also have an erection and an orgasm feeling without ejaculate. So it's important that we separate them in our mind as three separate things. And I think the other really important thing is that many men, and there's one of them I see that's in this webinar now, will tell me that their prostate, post-prostate cancer treatment orgasms are better than they've ever been in their life. And I think, you know, we don't really know the reason why that is, but I think the best theory is that most men have never done a pelvic floor exercise until they've got this problem. And then they're working their pelvic floor so that they don't have to wear nappies or pads for the rest of their life and are continent, but the stronger your pelvic floor, the more intense the orgasm. So, yeah, I think they're really separate things, and it's hard for us to get our head around that.
Well, another point to make is the value of the tech ring in diagnosing psychogenic versus physiological erectile dysfunction, whether a man has post-surgery or just has erectile dysfunction. So if someone is concerned that they're not getting erections, if you have a nocturnal erection, you get the tech ring and you have nocturnal erections, there's usually some psychological issue involved. And we've had, on the other hand, focus on the prostate issue, I recently spoke with a man who had not had an erection in over 18 months, 20 months. He wanted to know what could we do for him. And I said, probably not much, because the rings don't produce erections themselves, but it will tell you whether you should get back on the therapy that he'd stopped, because he'd stopped pumping, stopped doing exercise, etc. And he was having nocturnal erections. And
I'm sorry.
After a period of time, he was actually able to have sex again. Not even that long a period of time, a matter of weeks, as I recall. As far as I did ask Dr. Mulhall, who's the only person who could actually give me a number, how many men report better orgasms after surgery? And he says, well, we're the only people in the world to study this. and the number is 10%. And that was interesting, because I don't think people are thinking about that at all.
Well, it's interesting because I actually last year sent an email to over 4,000 patients of mine, and we got 2,500 roughly back, and we had a 60% of people said their orgasm was better. 10% said it was unchanged, and 30% said it wasn't as intense. So, and, you know, I didn't delve into it any further than that, but I suspect that the 30% that were unchanged were probably also the people who hadn't been very proactive about exercising their pelvic floor and doing all the right things. And I also think, from something you just said then, Elliot, that is of note, is that because it takes such a long time for these nerves to heal and wake up, I think people lose momentum and they're like, what the hell am I doing this for? Nothing's happening. And I think it's really important that in most men, not much happens at all to their improvement in the first 12 months after surgery, and then it starts to go better in the second year. And so it is a matter of being patient. And it's particularly frustrating when your PSA is 0, you're dry, everything else seems normal in every way, but you've lost your erectile function. And all I can really say to people is, please keep exercising it, because you don't want to end up with a problem where you've got a bent penis because you haven't stretched the muscle, and then your nerve wakes up and you've got this kind of skewiff, bent-looking erection that's useless, or a shrunken penis and you can't stand up and pee anymore. So it's not just about sex. It's about keeping those muscles healthy. And if you had a knee replacement, you'd do it. So why wouldn't you do it in this situation?
Just taking one more look at the questions here before we wrap up.
There was one question here about someone in there says that using injections is expensive. Well, using injections shouldn't be expensive if you're getting it from the right place. Like, there are some providers out there that do it on a subscription thing where they charge you an absolute fortune every month to send it out to you, but that's not necessary at all. The actual ingredient is about $8 Australian a shot. So you should only need to see your practitioner. Like, if I've got men on injections, I only see them once a year after we've set them up. So it shouldn't be expensive. And if it is expensive, then you maybe need to reconsider where you're getting them from.
That's good advice. Well, Melissa, I want to thank you. This is really a great discussion. I'm sorry, Dawn. Someone else?
Yeah, no, I'm just answering.
No names.
Okay. My final question, which is about, that the gentleman is asking whether the O-rings really do they really make a difference? And I think they do, especially in combination with a shot, which will make you erect. Then, the constriction band is a mechanical solution. It keeps the blood in.
It definitely they definitely make a difference. And also, on that note, I've recently given these to my son, who's in his late 20s, and some of his mates. They all wanted to try them. Every time I see them, they're like, "Have you got any toys in our car we can try?" So, and the 4 of them that have actually been brave enough to tell me have all said their orgasm's more intense. And these are young men that have no problem with their erections at all. So who doesn't want to have fun?
If I had advice for men in general, it would be put a ring on it. Beyond rock hard, there's not, the cock ring can get a man harder than rock hard. I'm bemused because most of our customers, by what your son said, because most of our customers who are actually buying the Max PR are buying it not because they have a medical problem. They're buying it because they want to enhance their pleasure. I want to say we will soon be coming out with a vibrator, more female focused, but it can be used by men as well too, that will slide on and off any of our rings, called Duet. We'll be selling that this summer. And that will be, a complementary product, and it'll facilitate mutual pleasure while having intercourse.
Oh, speaking of vibration as well, there's a lot of research that shows using vibration down the shaft of the penis actually helps restore the nerves. Like, any damaged nerves can, like, they do it for shoulders and things like that, vibration therapy. So I recommend another product at the moment for that. But I think having vibration in a ring will be really good, because vibration has been shown to get nerves to heal. So for me, it's just all about, there's not one perfect solution. It's about doing all of the different things.
Well, also, I want to make a quick pitch here for Melissa's Penis Project series. She has a series of 7, is it 7 videos, Melissa, that really go into all the different treatments. So if you're interested in the pelvic exercise procedure, that's addressed in those videos. Is that correct, Melissa?
Yeah, so it's basically, I have a penile rehabilitation program for people post prostate cancer treatment, but if you're it's great, because there's a whole module on what to do before to get your optimum recovery after. And there's 7 modules, and then it goes through why you're doing all this, because most people don't even know how erection works until it doesn't work. So why you're doing it, how you do it. It's very prescriptive there's videos all the way through on how to use a pump, what's pumps are the best option, and there's a few. How to use a lasso, how to do injections, how to talk to your partner about it. And I think it's a really good thing for partners to watch it as well. And you get, so it's 7 modules. It's about 5 hours of watching. There's worksheets, information, everything you need to know. It's basically everything that people get in the first 5 to 7 consults that they see me face to face. And then people have the option, if they want to, after they finish the program, to book an online consult. And if people are in other countries, that's not an issue. I will then write to their GP or their urologist and make some suggestions about what medications they might need to move forward. And if they're in Australia, I can just prescribe it.
Well, I want to say, if there are some questions we haven't gotten to, I'm available at Elliot, ELLIOT, at myfirmtech, myfirmtch.com to answer these questions. And if you want to discuss any issues or concerns, or about the use of the product, you can find me at that site, or you can just go to myfirmtech.com. Melissa, you want to put in your email address?
Yeah, I just put into the chat my website, and then my direct email address is melissa@melissahadleybarrett.com.
Yeah. Okay.
Well, thank you, everyone. Thanks for joining. Melissa, thanks so much.
Thank you. Thanks, everybody, for coming. There's quite a lot of you in there, so that's great. Sorry if we've missed anybody's question.
Damn, I didn't write. Hang on, I'm just going to put in Elliot's email address too. Okay.
There was also a physiotherapist in the chat room, and whoever that physio, I would love to talk to you more. So if you flick me an email, the name was Jen. That would be great. Send me an email and we can chat.
Bye-bye.
Okay. Bye, everybody.